third session of our four-part series of Basics of CRRT, in which we discuss, till now we have discussed what the dialysis membrane selection should be like. We have also seen the modalities of renal replacement therapy, especially CRRT. And today is the session on fluid management in CRRT, which again is a tricky proposition, but if handled correctly, will benefit the patient and have immense benefits. It's also Diwali time, and I know a lot of the viewers would be busy in festivities. A very warm and happy Diwali to all those who celebrate it. From Nephlearn, from myself, Dr. Ashwini Kulkarni. Today's session on the basics of CRRT, in which we'll talk about fluid management, will cover not only the calculations that are required to take care of fluid management and which parts to monitor, but it will also cover the types of dialytic fluids which are available and which can be used. So without further ado, let's dive into the topic.
Important component of CRRT is the management of fluid balance. Whether it's a machine fluid balance or whether it's a patient fluid balance, positive, negative fluid balance, all this has to be carefully monitored as the patient undergoes huge shifts in volume and solutes and electrolytes. So let us take a look at these features in this upcoming lesson. So first, with a very brief example, let's understand how this fluid balance is actually calculated. So in this example, we have a patient who is on CVVHTF and there is a dialysate flow rate which is set at 1000 ml per hour, a replacement fluid flow rate which is set also at 1000 ml per hour, and an anticoagulant infusion flow rate which is 100 ml per hour. So in effect, the patient is receiving 2100 ml of fluids per hour. At the same time, the effluent flow rate is 2300 ml per hour, which means that for every hour of treatment of CRRT, the patient has a negative balance of 200 ml, which means the patient has removed 200 ml of fluid, or rather we have removed 200 ml of fluid from the patient's body per hour. Simple so far, but actually the patient in an ICU, and that too with hemodynamic instability, also receives a lot of oral fluids through nutritional supplements, and he also receives a lot of intravenous fluids like vasopressor support and other methods, maybe blood transfusions, maybe plasma, and so many other things. And therefore, a very important component of CRRT therapy is a very frequent and regular review of the nursing orders. Let's check out this small example where the patient, in addition to our CRRT therapy, also needs about 600 ml of fresh frozen plasma, and about 2 bags are to be given in each hour. So, at such point of time, the patient needs further adjustment of the fluid balance. And so in this patient, we have a dialysate flow rate of 1000 ml per hour, a replacement fluid rate of 1000 ml per hour, an anticoagulant infusion rate of 100 ml per hour, which means 2100 ml is being pumped into the patient per hour. And the effluent flow rate is now 2600 ml per hour, which means a negative balance of 500 ml. But now we are adding to this 600 ml of additional fresh frozen plasma per hour only for 2 hours. And therefore, for these 2 hours, it is essential to increase the effluent flow rate by 300 ml per hour so that we are able to maintain the target negative fluid balance that we desire. To make things easy, we should encourage a separate prescription for these additional fluid requirements other than the machine fluid balance chart. And also, fluid balance prescription should be maintained for a 12-hour period, which makes shorter and more accurate assessment of fluid status. Here is an example of how this prescription can be maintained. We can add the name of the patient, the unique ID number of the patient, the overall fluid balance which is desired in the 12-hour period, and the overall fluid balance which has been achieved in the 12-hour period. We can also add additional information points like the right atrial pressure notification range. CRRT therapy mandates that it shall be initiated only when there are clear written orders which are signed, named and dated by the physician, following which there should be regular monitoring and recording of the fluid balance. How much is the intake and how much is the output. All this documentation can be maintained in the electronic medical records or even at the bedside by using a pocket calculator, and this can be then charted. By giving a regular running hourly balance, we can easily monitor whether the prescription is being met, whether the desired fluid balance is being achieved, and whether there is the right direction and the right dose of CRRT being given. Despite the best of the monitoring and the best of the intentions, CRRT therapy is often interrupted, especially with critically ill patients. And this is known as the downtime of CRRT. One of the common reasons for downtime is filter clotting, which may occur due to various reasons. Another common reason is that the patient is interrupted in CRRT because of certain procedures being done, like insertion of a central vein or something similar. Or the patient may be sent out for investigations such as CT scan or a PET scan or even a gastroscopy, and so many other reasons. This interrupted CRRT therapy or downtime in the CRRT therapy results in the following. Here's an example. With 5 hours of downtime, and if we had set a fluid balance of 200 ml per hour for a certain patient, this would result in nearly 1 liter of planned fluid removal failing to occur. Not only that, there are several times machine alarms which may relate it to the patient himself. So there may be frequent leg flexion in patients who do not have a femoral catheter, or patients may simply be agitated, or they may even sit up in bed, and in the presence of a subclavian catheter, this will then result in reduced blood flow rates. Occasionally, even replacement of the substitution fluid or the effluent bag, drain bags, these may also result in a downtime of 5 to 10 minutes per hour. And this in a whole day of 24 hours translates to quite a lot. And so, in order to prevent such missed opportunities of fluid loss being achieved, many physicians recommend that a higher goal of fluid balance should be set while performing the CRRT. Also, we must remember that there are many machine-based methods which allow the operators to check the actual fluid removal achieved over a given time. Some nursing protocols also mandate that a fluid balance should be checked every hourly, especially if there are inexperienced nurses. In periods of circuit instability, there should be a proper charting and a review of whether the fluid prescription is being achieved or not. Machine-based fluid calculations should be done. And finally, both the nurses and the doctors and technicians should be alert at all times to the patient hemodynamic stability. So how do we ensure that fluid delivery is being monitored and the removal is being accurately done? First of all, frequent patient assessment. Hourly charting has already been mentioned. But more vigilance related to other procedures. That is, like I said, either procedures on the patient, or the patient is being sent out for investigations, or maybe he is receiving additional nutrition supplements or fluids, changes in antibiotic therapy, and so many other things. And this is important because we must give attention to every small detail. Also, we must avoid dangerous fluctuations in or wide swings in the fluid status of the patient. And finally, A detailed and complete operation of the machine is essential, and so an experienced technologist must be available. What's important to remember in fluid management of the patients in CRRT is that inadequate fluid removal will result in imbalance in the patient's body, and this can result in other consequences like pulmonary edema and so many other things. But at the same time, an excessive fluid removal can also occur since we are infusing such large volumes of fluid, and this again should not be done. The best practice can be achieved by a thoughtful and frequent assessment. Like I said, attention to detail is very important, and monitoring of the patient is very, very essential. If we give clear and explicit instructions and prescriptions of the goals of therapy, then we are sure to have a winner. Let us now understand the fluids that are actually used as replacement or substitution fluids in CRRT. Initially, substitution fluid was prepared locally, either by the pharmacy or the nursing who were in charge. But this produced very catastrophic results, and so it was finally improved upon by the Acute Dialysis Quality Initiative and the KDIGO guidelines, and now commercially prepared sterile fluids are now available for CRRT as substitution or replacement fluids. These commercially available dialysate or substitution fluid replacements must have physiological resemblance to plasma water, and in some instances they may contain slightly lower potassium levels and slightly higher buffer content. They must be sterile and pyrogen free, and earlier commercial dialysate did not have any microbiological conditions, but now sterile bacteriologically fluids must be used in CRRT which have a viable shelf life. These are some of the electrolytes mandatory in the CRRT fluids, including sodium, potassium, calcium, magnesium, phosphate, chloride, glucose and iron. And we shall take a look more in detail at each of these. Sodium is usually kept at the physiological levels. However, in the use of anticoagulants such as citrate, there are variable levels of sodium in the citrate anticoagulant, and so the sodium level may have to be changed accordingly. Sodium levels may also be prescribed depending on whether the patient has hyponatremia or hypernatremia. Potassium levels need to be adjusted to remain in the physiological range and within the normal limits. In patients with hyperkalemia, sub-physiological potassium levels may be wanted. Also, in patients with severe gastrointestinal potassium losses, potassium supplementation may be required. Calcium must be added to the replacement fluid and dialysate during CRRT to maintain a normal ionized calcium range. Augmented calcium levels may be required if patients have hypocalcemia, and reduced calcium levels may be required if the patient has hypercalcemia. When citrate is used as an anticoagulant during CRRT, then very low or little calcium should be present in the dialysate or the replacement fluids. And in order to supplement this low calcium levels, then intravenous calcium is infused to replace the losses in the effluent. Dialysate and replacement fluids should contain sufficient amount of magnesium in order to maintain it in the normal physiological range. In patients with CRRT, hypophosphatemia commonly occurs because of increased clearance and because of intracellular shifts from refeeding. And so phosphate must be present in the CRRT dialysate or replacement fluids in order to avoid this hypophosphatemia, because hypophosphatemia can result in effects like muscle weakness and even rhabdomyolysis. Phosphate may also be given as an intravenous supplementation if needed. Chloride needed is calculated as per the difference between the cations, that is sodium, potassium, magnesium, calcium, and the anions. And this is done in order to maintain the electric neutrality of the solution. Hyperglycemia commonly occurs in these patients, and so all dialysate fluids or replacement fluids should contain very low amounts of glucose, or even glucose could be absent. Also, any other intravenous fluids which are given as supplements should also have as little glucose as possible. Trace elements including water-soluble elements, micronutrients, folate, amino acids should be replaced as required. Both lactate and bicarbonate have been used as buffers in dialysate fluids and CRRT replacement fluids. Historically, lactate was preferred over bicarbonate fluids because of the instability of bicarbonate fluids, especially in gas-permeable plastic bags stored over prolonged periods of time. Control trials have shown that both lactate and bicarbonate are equally efficacious in dealing with metabolic acidosis during CRRT. However, recent studies have shown that bicarbonate has more efficacy in dealing with metabolic acidosis as compared to lactate. When lactate is used as a buffer, the high levels of lactate in the blood may be clinically misinterpreted, whether this is physiological or whether it is because of the lactate buffer being used. Hyperlactatemia confuses and causes concern because it may lead to increased urea generation, it may lead to hemodynamic instability, and it may lead to cerebral dysfunction. And so, lactate is not preferred. Hyperlactatemia may also develop in situations where lactate buffer is used with high volume hemofiltration. In patients with impaired lactate clearance, such as in liver failure or with low tissue hypoperfusion, then the patient may develop accumulation of lactate. If D-lactate accumulates, this cannot be metabolized by the humans, and this can then result in neurologic impairment. And in such situations, therefore, bicarbonate buffer is preferred. Acetate is associated with impaired myocardial contractility and decreased cardiac function, and therefore is rarely used as a buffer in CRRT. We know that citrate is used as an anticoagulant during CRRT, but citrate can also be used as a buffer. However, not much is known about its use as a buffer during CRRT. Citrate metabolism is impaired in patients with liver disease or even with muscle hypoperfusion, and this poses the risk of hypercitratemia. Hypercitratemia, along with it, now carries the risk of low calcium levels in the body of the patient. In addition to CRRT, if the patient receives blood products or even plasma infusions, these also contain citrate as anticoagulants, and this can again increase the levels of citrate being given to the patient. After having learnt about the various buffers that can be used, these are some of the key takeaways. First of all, bicarbonate today is the preferred buffer which is used. Lactate can be used, but we should remember that L-lactate is preferred as D-lactate cannot be metabolized by the humans and will just accumulate, causing hyperlactatemia. Lactate also should be used in caution in patients with liver failure or very severe tissue hypoperfusion. Acetate is usually not used or not recommended because it causes cardiac depression. And finally, citrate can be used both as an anticoagulant and a buffer, and the clinical judgment should be used according to the patient characteristics about when to use citrate as a buffer. This buffering ability can be used even for patients with acute respiratory distress or acute lung injury who are on ventilator therapy for saving the lungs. The respiratory acidosis can be compensated partially or even completely using bicarbonate buffer solutions. during CRRT. However, the level up to which this pH can be corrected is controversial, and it has been recommended that we should avoid severe acidosis that is less than 7.2. Let us take a look at some of the fluids that can be prescribed. For example, A fluid can be used in a patient who has a relatively stable electrolyte and acid-base status. Fluid B can be used in a patient with hyperkalemia, but care must be taken that we do not cause iatrogenic hypokalemia, and so IV fluids containing potassium may be given to maintain the potassium within the physiological range. Similarly, fluid C has no calcium and a low buffer level, and so it can be used in conjunction with citrate anticoagulation or citrate as a buffer. The fluids can be adjusted according to the patient-specific factors, and in patients with very severe electrolyte and acid-base disturbances, we can modify the fluids accordingly. In patients with severe acidosis and with severe hyperkalemia, we may use fluids which have low potassium levels and also high concentration of bicarbonate. But at the same time, some clinicians may recommend that the fluid should be prepared locally and a custom fluid can be compounded. However, there may be compounding errors, and so the fluid which is prepared should be checked first before use. In addition, various types of fluids can be compounded and customized. For example, we may add electrolytes to supplement the fluids, or we may add sodium or potassium phosphate in order to prevent phosphate depletion, or we may even add bicarbonate so that severe acidosis can be taken care of. I hope you have enjoyed this lesson on the fluids which are used in the management of CRRT and how we can modify these fluids. We must remember at the end that both lactate and bicarbonate can be used as buffers, although bicarbonate is the preferred buffer today in CRRT. We must also remember that citrate is not just an anticoagulant but also acts as a buffer during CRRT. And with this, we will see you in the next session on how to manage the dose and the prescription of CRRT. See you there.
So that was our lecture on fluid management in CRRT, and I hope it makes things simpler to understand and simpler to follow and implement. Our effort at Nephlearn has always been to simplify things in a way that students can understand, so that complex terms, complex concepts are made very easy to understand and therefore implement. Many of you have been reaching out to us with requests for specific topics. This series is going to end with one more lecture, and however, you can explore our full course of 20 lectures on CRRT basics, and you will get a certificate at the end of the course also. Very soon we will be starting webinars again, which we used to do earlier, and this fourth lecture in this four-part series will be taken on the 9th of November, because on the 2nd of November we have a very important event, and that is Dr. Dhananjay Ukalkar, who is the nephrologist and my husband, is getting a Lifetime Achievement Award from the Nephrology Society of Vidarbha of India. It's a prestigious moment for us. 30 years of hard work in the field of nephrology and dialysis, a lot of innovations, including work with the National Institute of Technology, VNIT, Nagpur, where they have patented and developed a whole device which is to be used in the construction of AV fistulas, so that AV fistula construction does not fail. Today, the failure rate of AV fistula construction is pretty high, and therefore the prototype has been developed, and this entire program was dealt with by a PhD student who was awarded a PhD based on this work. Dr. Ukalkar was the guide along with the engineering department of PNIT and the veterinary college, where they did goat animal experiments, and it was very successful. Other than that, we've done a lot of innovations in teaching and learning of dialysis technicians in green nephrology. Even today morning, we had a small program where we used Dialyzer cans as plant holders, and we just finished spray painting and decorating those. I will put up the pictures on my YouTube channel, and you will be surprised at the creativity that we achieved today. With this, let me say once again that the next and the last session of this four-part series will be held on 9th of November, and I'm sure many of you will be interested in this last session. Following this four-part series, we will be starting our webinars, and for which we will be inviting you to register yourselves, and it will be held on Zoom. I have exciting partnerships and collaborations coming up for you. So we have from Tanzania, Mr. Benjamin Lubusle, and others also who are corresponding with me currently, and we will soon be announcing our webinars together. I hope you enjoy this multicultural, multilingual events that we are going to develop for you, produce for you. With this, we'll end today's session. Thank you very much for joining in, for watching, and for subscribing to our channel, and hope you continue to learn with us. Thank you.